ahead and go to the first slide, or the next slide, please. So management of patients with opioid use disorder on MAT is essential to talk to these patients about pain management before delivery. So when they're seen in the office, this is one of those things where pre-delivery discussion can help their management plan and help how they respond to management in both labor and delivery. The one thing that we have to make sure is that they don't expect to be pain-free. And that's why the discussion is so important. As long as these patients understand going into it that we want to reduce their pain or make their pain tolerable, understanding particularly with C-sections, vaginal delivery is a little bit different. Many of the vaginal delivery patients really do well with minimal to no additional pain medication. But anytime you have intra-abdominal surgery or other types of surgery, pain management can be very difficult. So just letting the patient understand that it's going to be a challenge and we have to work with them during that process to make sure we treat them the best we can and as appropriately as we can without putting them or their baby at risk. Next slide. So intrapartum care is a little bit different for pregnancy. The one thing that is absolutely the best option, if we can do it, if the patient has normal platelet count and agrees to regional anesthesia, that controls their pain with minimal to no additional opioid treatment. And it just, if you explain this again, the pre-delivery consultation discussion is paramount to helping them understand that. You can use additional pain medications as needed. And if they don't go for the regional anesthesia, you can use IV pain medications, but they have to understand a couple of things. They have increased tolerance, so they require more of the pain medication, and sometimes to a level that physicians don't feel comfortable giving them any more than what we typically do. The other thing to really focus on is to avoid the agonist-antagonist medications, Stadol and Nubain, which are two that we commonly do use here in particular, but they can throw these patients into withdrawal, so not to use those in these patients on MAT. Next slide. So the other thing during the intrapartum period is to continue the maintenance therapy in the doses typically that they were on. So what I like to do when they're in the hospital, if we're either inducing their labor or they're there with ruptured membranes, have a prolonged course, we continue the maintenance therapy in the doses that they were on, but I do like to divide the doses, particularly with methadone. Methadone is given once a day as an outpatient, and it's primarily because of the need to go into the clinic to get those drugs. There's no question the studies do show benefit if they could take that methadone, split it half in the morning, half at night. It gives better control with less somnolence. And when they're in the hospital, we can write it in divided doses. So that's what I really encourage us to do. And here in our program, that's what we focus on, is trying to make sure that we split that dose so that they don't have that somnolent effect from the medication. Next slide. Postoperatively, and I throw in the postoperative to include vaginal delivery as well as C-section. Again, with vaginal delivery, most of the time you can get by with just the maintenance therapy and additional Tylenol. But we continue the maintenance doses. You can use additional opioid therapy with the maintenance therapy, so they can stay on their Subutex or they can stay on the methadone, and you can use additional medications. We like to use Toradol and acetaminophen. It works very well. It helps potentiate the effect. And most of the time, particularly again with vaginal deliveries, that's all you need. Buprenorphine patients, if you have to add opioid therapy, need about 50% more of the opioid doses that we typically use for pain control because of that agonist-antagonist effect. Next slide. So what we do with the Subutex or buprenorphine, we continue the maintenance therapy. And even though as an outpatient, we usually or typically will give them once a day dosing, again, when they're in the hospital, we will divide that medication into typically every 8 hours, maximum dose 24 milligrams total. We add, again, opioid agonists with high mu receptor affinity because that's what's required to give them the best effect if they need other opioids. So the ones that we like to use, morphine, fentanyl, and Dilaudid. The Dilaudid is kind of our go-to drug here. A lot of places prefer the fentanyl or morphine. Next slide. So typically, with buprenorphine, it's not great for pain control, but some patients are very motivated to just use the buprenorphine and they don't want other opioids. And if that's the case, it's great. And we've had very good success with this. Again, really has to do with patient expectation, pre-delivery counseling. When we use buprenorphine for pain control in these patients, we typically will increase the dose by 2 to 4 milligrams every 8 hours with the maximum, again, a total dose of 24 milligrams in that 24-hour period. Next slide. With methadone, a lot of people really do like to use methadone totally for the post-op care as well. We continue it till the day of surgery. Post-op, we may increase the dose if we're going to use it alone. Again, splitting that dose to morning and night, and it works very well. You can, and some people do substitute other pain medications like Dilaudid. Just stop the methadone and give Dilaudid or fentanyl for post-operative pain, and then switch them back to the methadone before they go home using the Tylenol and other agents that we'll talk about in a minute. Next slide. So additional medications that absolutely are so beneficial in these patients to help minimize the opioid need are just simple things like Tylenol, Toradol, and Lyrica or gabapentin. Both work very well in these patients to help propagate the effects of the maintenance therapy that they're on. And many of these patients get by without having to add any opioids. And that is so, so critical, as we'll hear about one of our cases that we're presenting today, that really drives this point home, because it's so important not to put them on any more opioids than they need because of their disease. Next slide. Basal or PCA, patient-controlled analgesia, is great to use for these patients and certainly can be done post-operatively in addition to the MAT, particularly the first 12 to 24 hours. You just have to understand that you may need a basal rate when they have this therapy. Frequently change the settings and be very careful using with sedatives for, like, if they need something for sleep or need something for anxiety. The one thing that it's just a point that I like to make here is for us as providers, and that goes from nursing to physicians, have to be so careful with these patients, not to be judgmental. It's not infrequent that I'll get a call from a nurse, or a nurse stop me in the hall and just say, this patient is so drug seeking, she just wants more and more and more. And again, it is very important for us to understand the increased tolerance that these patients have with pain medication when they've been on it for so long. They're going to have pain. They've just had a cesarean section, for crying out loud. They may need additional pain medication. So while we want to be very cautious about how much we give or if we give any additional, you need to be sensitive to that. And again, it goes back to the very first conversation of this talk, and that is pre-delivery counseling goes a tremendous way to help these patients do better postoperatively. Next slide. This is the last one, and we've said this with all of the discussions we've had on this topic. It is so important to make sure patients and staff understand that breastfeeding is not only safe, it's absolutely essential to both mom recovery, bonding, and good care for the baby. I think that it's absolutely so important for us to push this home to these patients. And even many of these patients don't want to breastfeed for various and sundry reasons. But I think the counseling needs to be, you really should consider breastfeeding, even if it's for a brief period of time. It does benefit outcomes for the pregnancy and for the patient. I think that is all of my slides. I made it very simple and straightforward so we could answer any questions.